Here we classify the complication of meningitis into early complication and late complication. Early complication includes inappropriate antidiuretic hormone secretion leading to increased intracranial pressure, as I told you. Recurrent or persistent pyrexia can be presented to you by recurrent fever, the meningitis, subdural infusion, and here in case of subdural infusion you can proceed into an operation to relieve this effusion and tension on the brain. Empyema and thrombosis of cerebral vessel, medullary coning, this is common in very young child, paralysis, and the late complications include hearing defects, which is not very common due to the otitis media, which occurs in cases of meningitis. Epileptic fits, the patient may present to you by epilepsy, and you will find that this patient have a history of meningitis. Persistent paralysis, relapse of meningitis, visual impairment, hypertension, hydrocephalus, and this hypertension and hydrocephalus due to inappropriate antidiuretic hormone secretion. If we discuss the treatment of meningitis, of course, if the patient presents to you by acute bacterial meningitis, this patient should be, first of all, should be hospitalized. You should admit this patient to the hospital, and you should give him a fluid, the form of glucose, Ringer solution, whatever, and this fluid should be monitored. What's meant by monitored? You should calculate the intake and the input and output of fluid. If the patient having fits or seizures or convulsions, you should give him an anticonvulsant to stop these seizures. And whenever you suspect a case of meningitis, you should start the antimicrobial chemotherapy. The drug of choice in case of adults from 18 to 50 years of old is third generation cephalosporin, including ceftriaxone or cefotaxime, plus vancomycin, especially if the bacteria which is susceptible to cause this case of meningitis is Streptococcus pneumonia or Neisseria meningitis or Staphylococcus aureus. If the adult is more than 50 years old, you should give vancomycin plus third generation cephalosporin plus ampicillin. In case of immunocompromised state, like a lot of states of immunocompromisation, like patient receiving a corticosteroid, whatever the cause, or a patient having an autoimmune liver disease, patient receiving chemotherapy, patient receiving immunosuppressive drugs, all those patients having AIDS or HIV infection, all these patients are immunocompromised patients. You should give vancomycin plus ampicillin plus third generation cephalosporin, or vancomycin plus ampicillin plus merovinam or meronem in its trade name in the market. The usual duration of therapy of pneumococcal meningitis, which is a common causative organism of meningitis, is 10 to 14 days. For Neisseria, 7 days therapy is adequate. Also, 7 days is adequate in case of Haemophilus influenza meningitis. The dose of vancomycin is 15 to 20 milligram per kg every 8 to 12 hours. Ceftriaxone 2 gram intravenous every 12 hours, or cefotaxime 2 gram intravenously every 4 to 6 hours. Ampicillin 2 gram intravenously every 4 hours. Cefobim 2 gram intravenously every 8 hours. Merovinam 2 gram intravenously in case of 8 hours. For empiric coverage in patients with severe beta-lactam allergies, vancomycin plus moxifloxacin. As you see here, moxifloxacin is not given except in case of beta-lactam allergy. If there is an allergy to the beta-lactam, you should give moxifloxacin 400 milligram intravenous once. Plus, if listeria coverage is required, if you want to cover the causative organism listeria bacteria, in patients above 50 or on those with defect in cell-mediated immunity, that you can give trimethoprim sulfa mesohexazole 5 milligram per kg intravenously every 6 to 12 hours. And thank you for your listening.